So I would like to introduce Hadley Heath Manning in our healthcare panel. You met Hadley last night. She's one of our Tony Blankley fellows, and we're just thrilled that she is here to moderate this panel. So I'm going to ask them to come on out, and then Hadley will introduce the panelists.
It's my life, it's now or never. I ain't gonna live forever. I just wanna live when I'm alive. It's my life.
Good morning. Can you hear me? All right. Welcome to the healthcare panel. I'm Hadley Heath Manning, and I'm Director of Policy at the Independent Women's Forum, and as Jennifer mentioned, a Tony Blankley now Senior Fellow with the Steamboat Institute. And I'm very proud to represent an organization that's inspiring Americans to greatness. We want greatness all around. We certainly want greatness in our health sector. And that's what our panel is going to be talking about today. I think it's titled, What's Happening to Healthcare in America? And so I'm going to set the scene a little bit and introduce our fantastic panel. And then we're going to get into a little bit of a discussion after each panelist makes some opening remarks. So what scene setting do I need to do? Everyone knows what's happened with the Affordable Care Act. It was a law that passed in 2010, and it's also known as Obamacare. It remains law to this day, despite the fact that, for a long time, about half the country has had an unfavorable opinion of the law, and many Republican candidates specifically have run on the promise of repealing it. And now Republicans control, of course, both houses of Congress and the White House. And over the course of this spring and summer, in some very high political theater, we saw the House pass a piece of legislation called the American Health Care Act, which is a repeal and replace measure. And we may talk about that a little bit on the panel today. And then the Senate deliberated several different types of repeal measures and voted on several different types of measures, none of which passed ultimately. And so it seems that the healthcare issue is more or less at a stalemate right now. But of course, we know it remains a high priority for the Trump administration and for Republicans, at least in Congress, to address these healthcare issues that remain. So our panel is going to be discussing this today, and I want to introduce you first to Beverly Gossage, who's here, she says, in her Nancy Reagan dress. Beverly is a health insurance expert, and she's been an agent for 14 years. She's licensed in nearly half of the states. She's also a fellow at the Independent Women's Voice, which I mentioned because I work there. And Beverly is a highly sought after speaker and advisor on health policy issues. She has the real world experience. She's a member of the National Association of Health Underwriters, or NAHU. And so it's just of tremendous importance that she bridges this gap between the real practical world of health insurance and the policy world. She was invited in 2006 to the Bush White House. And more recently, she's visited the Trump White House staff to brief them on some health policy matters. She also has spoken at many different major conferences, and we're pleased to have her speaking to us today. To my right is Dr. Eric Meyer. He's a board-certified anesthesiologist with 20 years of experience in anesthesiology and critical care. And I was reading his bio last night to my husband, and we live in Denver, and we enjoy hiking and outdoor activities. But my husband was very impressed that Dr. Meyer has summited Mount Everest from 2 different routes. Twice, yeah. So
10 fingers, 10 toes.
Right. So that's quite the amazing feat. And if your jaw has dropped, just keep it there, because this spring he was in Mosul, Iraq, working in a trauma center there. And so I think especially after Father Andre's presentation this morning, we can have a little greater appreciation for just how traumatic the events there have been. And Dr. Meyer works with Rural Partners in Medicine, which is a group that works to bring specialty care to rural communities and rural hospitals so that patients don't have to out-migrate for their care in urban centers. And I hope that he'll tell us more about that, because it sounds very intriguing to me. I'm a doctor's wife, and so anything you can do to improve the quality of life for doctors and patients, I'm in favor of. Frank May is with us. He's the CEO of Yampa Valley Medical Center right here in Steamboat Springs. He's been at Yampa Valley Medical Center for 19 years, and he's been the CEO for the past 5 years. His experience is in hospital administration, hospital finance, and physician practice management. He's also a board member of the Colorado Hospital Association, and so we're glad he's here to offer that perspective and tell us what's happening as a result of different health policies in the hospital world. And finally, we have Grace Marie Turner. And Grace Marie, many of you know Grace Marie. She's on the National Advisory Board for the Steamboat Institute. She is the president and founder of the Galen Institute, which she founded in 1995. And Galen is enormously important in influencing the conversation about health reform. Grace Marie has been involved for many years. She wrote a book called Why Obamacare is Wrong for America. She's been published in the Wall Street Journal, the New York Times, USA Today, and many other major newspapers. I've never seen a who's who, a list of big players in health policy that didn't mention Grace Marie Turner. And she's, I will say on a personal note, been a very generous mentor to me and has taken me to lunch and has reviewed articles, drafts of articles that I have written. And I can say this of Beverly too. Both Beverly and Grace Marie have taken many phone calls from me offering me advice. And so it's great for me to have a couple of my mentors on today's panel. And so with that, we've just got a little bit of time today, but a tremendous amount of information to work through. So I want to open the floor to Beverly first to give us sort of her perspective, and then we'll move through the panel.
Well, first of all, I want to say thank you, Jennifer and Rick, for inviting me. And this has been such an informative weekend, and I've really enjoyed my time here with all of you. Let me begin by saying typically I do hour-long, 2-hour-long workshops about the ACA. And I have 5 minutes. So I jotted down a few notes to make sure that I stay within my 5 minutes. Let me begin by saying that there have been a faction of folks for many years who have wanted to take over the healthcare industry by the federal government. And in fact, most recently, there were 5 to 7 studies that were done asking people if they were satisfied with their health insurance. The average of those studies was 87% of people said they were satisfied. But this didn't stop those who were determined to figure out a way to take over the private health insurance marketplace. So knowing this, their tactic was, we know most of you love your plan, no problem, you can keep that. And you can keep your doctor. And hey, in fact, we're gonna lower rates by about $2,500 a year, remember that? So what really did happen? Well, they had to sell this to America, and the way they sold it was this: demonize the private market. You guys are all great. We're just going to help these poor saps over here in the private market. Trust me, it's awful. It's a wasteland. It's terrible. People in the private market were going, they're not talking about me, right? I love my plan. It's great. We have 17 carriers in our state, and must be another state. I don't know who they're talking about. So they started saying things like this. How many of you heard Nancy Pelosi say, carriers can raise your rates the minute you get sick in this private market? They can drop you if you get sick. Well, of course, what we know is that's been against the law since 1996 with HIPAA. Did we hear any of the media say that's not true? Was that given 4 Pinocchios? Did you hear any Republicans stand up and go, wait, what? No. So people believed it. And then the next thing was pre-existing conditions. I know you've never heard that term, right? That's new to everyone. Let's talk about that. Basically, if you listen to the stories, you were told that no one could get a private policy. Oh my goodness, if you had acne, that's the famous statement. You couldn't get it. But actually, that's not true. They never ask you a question about on a health questionnaire about did you have acne. They might ask you, what prescriptions did you take? If you said Accutane for acne, such a dangerous medication was finally taken off the market, but you would not have received a private insurance plan if you were on Accutane. Now, the minute you got off of it, that would be fine. So they turned that around and said, if you had acne, you couldn't get a policy. Let's talk about that for a moment. How was the marketplace before the ACA? Let's go back to 2009 real quickly. First of all, 35 states had what is called a high-risk pool. Those have been demonized. Then you had 6 states that did the ACA way. So 35 states did it, true health insurance. Why? Well, because the HIPAA law also said that every state had to guarantee that everyone had access to a policy. Did you hear that anywhere? How did they do it? Well, those 6 states decided that they would say to carriers, you have to offer policies to everyone. And you can't ask the health questions. That's what the ACA did, right? By doing that, carriers are blindly, actuarially trying to determine what rates would be. The other states said, well, we're not going to do it that way. We're going to still offer everybody a policy, but we're going to say, hey, when you apply, it's going to be true insurance. They will ask you all kinds of questions to determine your claims, and then the potential of claims will determine your rate. That's how it was done in the majority of states. If you waited till you got sick to apply for a policy, there was no mandate to buy. However, you would have to pay more in the high-risk pool. It's about 150% across the nation more than a standard policy. So what were those rates like? Because we were told outrageously expensive. Well, I can tell you from my state, and I'm from Kansas, and the rate in our state for a child's policy was $28 a month. Sound outrageous to you? For a 27-year-old, it was about $50. For a 64-year-old, it was about $165. These are not junk policies like you were told before. These are major medical $5,000 deductible plans. Now in Colorado, I have 2 rates for you. One was a 27-year-old was $159. Why so much more than Kansas? Because of the regulations in Colorado, that the state regulations could be changed to where your rates would not be as high. Family plans went from $1,000 to $1,400 overnight with the ACA. Well, what did the ACA do? Well, the ACA said these regulations, that's the core of the Obamacare law, is that, again, everybody, every carrier has to give everyone a policy no matter how they present at application. Can't ask the health questions, so you can imagine rates would be very high, right? Second thing was called community rating. So the only difference in community rating is they said everyone has to have the same price. Well, we can do an age band, and we'll say, if you're 64, you cannot pay more than 3 times what the young people pay, and vice versa. If you're 19, you can't pay less than 1/3 of what a 64-year-old would pay. It's called a 3-to-1 age band. Did you know in several of those 6 states, I think there were 5 of them, they had a 1-to-1 age band? 19-year-olds paid exactly the same as a 64-year-old before the ACA. It actually lowered some rates in those states because of that reason. The other thing was, you've heard about age 26. Age 26 had to do with keeping dependents on your plan. Now, what most people didn't realize is many states already had age 26, 28. In fact, Florida said age 30. So states could have made those determinations. Also, women were a pre-existing condition. Were they? No. It's that women may use their policy more, may have more claims. So during certain times of their life, their rates may be more. You get to be 55 and men were actually more than that. So to wrap up my 5 minutes, and I hope I'm not going over, I don't think, and that is that networks were changed. So the result of the ACA was these regulations on carriers, those 2 especially, essential health benefits that had to be in the plan, they knew the moment that they passed these regulations, rates would go through the roof. So then they had to have this extra layer, and that layer was, we better subsidize people. We'd better have a mandate that everybody buy because only the sick people will buy. We better fine people if they don't. We better have an exchange to be able to disseminate these subsidies. And finally, we'd better expand Medicaid so that more people have access to that because we're raising these rates really, really high. The next layer was, how do we pay for all that stuff? And that was the 28 taxes that you hear about. So that at least gives you a foundation of what happened before, why America was clamoring for repeal and yelling for repeal, but you didn't hear the average American out here saying, and replace. They just wanted it gone. They still just want it gone.
Okay, now we're going to hear from Dr. Meyer.
Good morning. It's an honor and a pleasure to be here. I'll try to give you a little bit of a physician's perspective on what's happening in America. But of course, it varies with one's perspective. I'm a physician. I'm also an entrepreneur running a business. And my perspective on insurance is going to be different probably than somebody who's had employer-sponsored insurance for years. But what I can tell you is that in terms of the physician perspective, that physician practice satisfaction parameters are at an all-time low. Physician suicide is at an all-time high, along with burnout and early retirement being opted for. It's creating a shortage of physicians demographically and geographically, and that's one of the things that's going to become even more acute. Just in terms of perspective, Hadley mentioned I did worked over in Mosul, and I'll give you a quick story there. I was working at an emergency field hospital run by Samaritan's Purse, and one day happened to be working alongside a surgeon friend of mine by the name of Dr. Paul Osteen, who happens to be the brother of Joel Osteen. And we were in the receiving triage area of this tented hospital facility when we received a 5-year-old boy who had been critically injured by an ISIS mortar attack with severe injuries to all 4 extremities and burn injuries. And this brave young kid was separated at the gate from his parents out of security necessity. We saw him clutching a 250 dinar note, and we asked the interpreter, what was the meaning of this? The interpreter said that his father insisted that he give this to you. That's about 40 cents to you and I. But that was all that family had. And just a reminder of where we are and the turmoil associated with our health care right now still is very, very good, and it's the envy of most of the world. And so it's important to maintain some perspective on this. Back on topic, a couple of the things I hope we get into discussion about. I think one of the things that the Obamacare mandate has definitely brought about is detrimentally is narrow healthcare networks. And basically driving excessive coverage and raising prices, essentially. Congress is really going to have to act fast to stabilize these markets in the short term. But it's my opinion that what's needed is a catastrophic health insurance plan that's accessible. It could take several forms, most likely backed by the states, and this has been borne out in several states with risk insurance pools, and allowing other care to float on the free market. And this needs to be transparent in terms of cost. If you all listened to Steve Forbes last night, he emphasized this. There's too much horizontal integration and not enough vertical integration in healthcare right now. Several studies have shown horizontal integration drives up prices, decreases quality, and reduces competition. The last thing we need right now is reduced competition. We need more competition, and we need more public-private partnerships. And I can get into that in terms of the business that my partner, Dr. Brian Shear, and I run. But basically, what we need to do is do the exact opposite of what horizontal integration is doing. And I'm going to be interested to hear from Frank May about how the merger between our local hospital and University of Colorado, a horizontal merger, can decrease cost while improving quality, because the literature really doesn't support this. And finally, the ACA mandate for the electronic health record is something that many of you, if you're outside of the medical nursing sphere, are probably not aware of. But essentially, what that was done was basically to improve transference of medical records and efficiencies associated with that. It's been a huge problem, and the way it was rolled out has actually been shown to have been detrimental to healthcare, and it was done in a limited manner of contractor providers by the Obama administration, of which I'm critical. And I'll refer you to a paper by Christine Sinski, MD, and it details that for every hour of patient care a physician is involved with these days, there's 2 hours of work on the computer and another hour of personal time associated with that. And those that are not involved in the medical field may not realize why a lot of us went into this profession. And there's an intangible that's called emotional labor. It was coined by a sociologist named Arlie Hochschild. And that's basically the fundamental aspect of care, which means taking personal and professional and emotional stock of what you're doing. And when you're simply checking boxes in a computer to generate a record whose primary goal is to ensure maximal billing, then there's a problem. And that is something that is not talked about enough. I'm going to wrap up there. But basically, Obamacare, I believe, was designed and intended to fail, basically to force a single-payer system on us. As I said, more competition, not less, is needed. To anyone who listened to Steve Forbes last night. And it seems this country is trying to move in a direction that Europe has already been and Europe is moving away from. So hopefully we'll act, and we'll act decisively as a nation.
Thank you, Dr. Meyer. And now we'll hear some remarks from Frank May.
Thank you, and thank you all for allowing me to be here today. You know, from a hospital perspective, and I'm going to give you a perspective from a rural setting here and what we have experienced in Steamboat Springs. I've been in a healthcare environment for 36 years in my career, and I've really seen a lot of changes in what's happening with healthcare. And I think the biggest change that we're seeing is that we are moving away from taking care of people that have either had some genetic problems or have had injuries and being brought into a healthcare situation to really experiencing more from the standpoint of the social aspects of what's happening economically, what's happening with basically in family settings and those types of things. And we are really seeing a shift in our patient population that's requiring much more attention to social needs. And those things are related to alcohol abuse, substance abuse, and behavioral health. And you can classify that in a lot of different things. But I think is what Eric was speaking to is that the change in what's happening in healthcare and what the lack of resources around us being able to really care for people that are having and experiencing those types of challenges is really drawing on the physicians, the nurses, the staff that are being tasked to take care of them. And so I really think what we're seeing is just, you know, a kind of a migration away from taking care of people when they're sick to really taking full accountability to the full scope of not only the health, but it's also the social well-being of people in our country. And I think that shift has really happened to the medical community, and it's why we're experiencing some of the things that we're experiencing. You know, one of the things I've heard from a lot of you in this community, and it kind of gets back to what Eric was talking about, and I don't know how to fix this, is why do I have to tell you what happened to me 6 months ago when I came in? Why isn't that in a record? Why didn't whatever happened at Steamboat Medical Group, why didn't the doc at YBMA know about that? Why doesn't the doctor at the ER doc at the hospital know I just had a lab test in one of my physician offices? And I think that those are the things that, you know, the electronic record is supposed to solve, that it's not. And how we get there, I think, is going to be critical, because I know that's what I'm hearing from a lot of you, is that you want that continuity of your record, you want people to know, or you want the caregivers to know what's happening and what has happened, but our infrastructure just does not support that right now. So from a hospital perspective, again, I see us repeating tests, I see us rerunning labs, I see us doing x-rays that probably don't need to be done. And somehow we're going to have to get out in front of that. And then also the other thing is I feel like in the healthcare industry anymore, we're kind of playing checkers in the rules of chess. We really have, you know, our payment structure does not fit with the care delivery model that we're asked to provide now. We're basically, I think, have a payment model that was structured back in 1984 around DRGs and those types of things. DRGs are diagnosis-related groups that were applied to inpatient care, and we're still getting paid in the same way that we have. Physicians are still getting paid in the same way basically on a per unit basis. And what people are looking for, and what I think that we're missing the boat on, is that this is not about a per click unit of cost anymore. This is really about a full continuum of care, and we have to figure out ways so that we're all going to be incentivized to do that and take care of people in a way that is changing with the environment. Technology has changed significantly over the last 3 to 5 years. We have access to things that we've never had access to before. We have telemedicine where we can actually deliver care through a television monitor and do a pretty darn good job of it. And yet there really is no payment mechanism for that, so it stymies the ability to really change the way that we're delivering care. So I don't have a lot of answers to the federal issues, other than, again, it's the regulatory environment that we're playing in does not work. The data that we're using, anything you see up on a screen anymore is dated in 2013 or 2014. It's 2017. We need to be dealing with current, real issues and not with things that happened 3 to 5 years ago. So we've got to move the healthcare industry forward, and we have to do a better job of understanding what the current issues are that are more socially based than illness based. And I would think that, again, you talk to any of our physicians, they're spending hours and hours of their time now dealing more with social issues than they are with medical issues. And we have to find a way to be able to support them and be able to support the people that are coming into the environment to just make sure that they're not getting a pat on the head and sent down the road and saying, oh, you'll be better later. Or we don't have resources to be able to take care of you, because it truly is a big challenge. And the last thing I'm going to say about our environment here locally is that we have reached the point where 30% of our population is being covered under Medicaid. From the standpoint of being able to access health care, I feel like that's something that is needed right now, because really there's not another option. But I think it's really sad when we think that 30% of our population has to be covered under a federal assistance program because they don't have an income or stability to be able to make their lives work. And so somehow we're going to have to address that as well.
Thank you. All right, Grace Marie.
Thanks, Hadley. Is this on? Yes. It's such a pleasure to be here with you, and I want to personally thank you for your support for the Steamboat Institute. I think that you can see from the Young Leaders program in particular that they're featuring today how important it is to cultivate the next generation of young leaders, because the fight for freedom is it's a battle that never ends. And having these young people, and what incredible return on investment for the stipend that they get through the leadership program, that they're able to continue the path of their passions. So I really thank Steamboat, thank Jennifer, thank Rick, and thank all of you for all you do. It's a pleasure to be here. I have been on this panel when Tony Blankley was our moderator, and it is wonderful to have his legacy continue here as well. So where are we with Obamacare? What a mess we have, huh? I think we need a new book called Why Obamacare is Still Wrong for America. It is, we knew it from the beginning when we wrote that book, the year the bill passed. We wrote it, passed in 2010, and we wrote it later that year to really anticipate many of the problems that we see today. And one of the things that's really swept under the rug is how many people are being harmed by this law. We have focused so much, yes, so much during the debate over, oh my goodness, 22 million people would lose their health coverage if any version of the Republican bill is passed, when in fact tens of millions of Americans are struggling with the cost of insurance that is often now more than their mortgages. I had an Uber driver the other day say that he had to work another 20 hours a week just to pay the health insurance premium for his family, which was more than his mortgage. And so we've got to figure out a way, and young people who are being driven out of the system because, as Beverly said, they're being charged so much more than their actuarial expectancy of use of healthcare services for their premiums. So what are they doing? They're dropping out. So what's happening to those pools is, of course, you wind up with more and more sicker and older people in the pools because the younger, healthier people drop out, and you really wind up with a death spiral. And that's really where we are headed with Obamacare. And one of the reasons that Congress has been so intent on trying to figure out how to repeal and replace the law. A couple of things that get almost no coverage about what was in these bills. They knew that you needed a safety net for people currently on Obamacare. Many people were driven into this program. They had policies they loved, but they were declared illegal. And they were forced to purchase health insurance. You were required to buy health insurance, and this is the policy, these are the policies that are offered, and you have to pay or you're going to be fined. And so people wound up being driven into the exchanges, even though they had coverage they were perfectly happy with. But we can't leave them without coverage. And so all of the bills that have been making their way through Congress would have provided a safety net, a temporary safety net to make sure that they were protected for a couple of years while we moved power and control back to the states to begin to provide policy options that they could afford and that they would actually choose to purchase. It also would have protected people with pre-existing conditions. It would have protected people under age 26. Importantly, it also would have reformed the awful Medicaid program, which often pays doctors so little that people are forced to go to hospital emergency rooms to get even routine care. They would have begun to change that program. Those were platforms of all of the programs. One of the tragedies of Senator McCain's vote, thumbs down vote, middle of the night on July 26th, was that, yes, it was a skinny bill. It was like a platform for reform. There were 250 amendments lined up to be voted on, what they call a vote-a-rama in the Senate, that would have been up and down votes on the individual mandate. It would on the taxes in Obamacare, on all of the specific provisions that Steve Forbes was talking about last night. We were ready to force members to vote on those individual provisions. So why did Senator McCain vote no? Why did he and Susan Collins from Maine and Lisa Murkowski from Alaska vote no, basically killing the Senate effort? It's because of Medicaid dollars. They don't want to lose this unbelievably generous match that they're getting for Medicaid money. Initially 100%, now 95%, going down to 90% match for an expansion population. These are young, often healthy, single adults who are childless and otherwise had not qualified for Medicaid. Now they're eligible for basically free coverage. So what's happened? They have signed up in droves. Not surprising, because they're also subject to the mandate, but they also now have the option of free coverage. There are now 72 million Americans on Medicaid, a program designed as a safety net program for people who have nowhere else to go for coverage. And what does that mean? First of all, it means in Ohio, for example, they expected that Medicaid spending was going to go up to about $14 billion a year, in addition to what's already being spent on Medicaid in that state between 2014 and 2020. They're now expecting it's going to cost $28 billion. Medicaid now costs more than education. It costs more than they're spending on public safety, more than they're spending on transportation. Medicaid is gobbling up state budgets. So what do? Senator Alexander, Tennessee, is chairman of the Health, Education, Labor, and Pensions Committee. And he is trying to find a bipartisan path, pardon me, to come up with a solution that can maybe even get 60 votes in the Senate so that you have more flexibility with what the legislation would be, but at least to get some Democratic votes so we can lose some of these so-called moderate Republican votes and actually get something passed. And two provisions. First of all, there are subsidies going to health insurance companies. We call them bailouts. That's money that it was such trickery with the health law, when the health law was passed, but basically they said that people under 250% of poverty, $30,000, $40,000 a year, depending on family size, would be able to get help with their premiums, not only their premiums, but also their deductibles and their co-payments. And this money was supposed to come as a supplement to the insurance companies to compensate them for that. Well, but Congress never appropriated the money. So there have been a lot of legal battles that it's illegal for the Obama administration to have spent this money without having it appropriated by Congress. They've got to fix this. So they're called cost sharing reduction payments. You're going to hear a lot about those in the next month. That's really sort of the anchor of what they think they have to fix. And in exchange, Senator Alexander said we must get more flexibility for the states. There are now 34 Republican governors who are chomping at the bit to try to begin to reform their Medicaid programs, to get health control back over their health insurance programs so that they can begin to do what the federal government has proven it is completely out of its element in doing, and that is managing the health insurance market. They can't do it. Only the states can do it. There are a lot of elite people in Washington who think, oh, we don't trust the states. I trust the states. I know that you are much better able to figure out how to get care to people. And I'll close with one story. Early in this debate, I had an email message from a dad who said, my daughter is on Medicaid. She has multiple disabilities. There's no way we could afford to care for her, or there's no policy that we could buy to protect her. If you add tens of millions more people to this program, she is going to be competing against all of them for the very few physicians, especially specialists, that she can see. He said, my daughter needs to see a urologist. I used to be able to get an appointment in a few weeks. The next appointment I could get would be 6 months for her. So what we're doing with Medicaid expansion is we're harming the people this program was designed to help. And there is an altruism in Americans in really wanting to help those people that are less fortunate. And by saying that what we're doing with expanding Medicaid, expanding government control, putting more and more money into federal and government money into health care, is that we're actually harming the people that most need our help. So that's really our agenda. We've got to figure out how to move forward in a way that allows people who can take care of themselves to do it, allows the market to work, explosion of technology that could help, and choices and options if the federal government would get out of the way, and then be able to take care of those people who really don't have anywhere else to go for care.
What a great panel. I see a lot of people taking notes. We're getting a wealth of information and knowledge about the health policy system in the United States. So I've got a few questions, and I want members of our audience to be brainstorming and maybe jotting down a few questions because I hope to have some time for Q&A at the end. My first question, I think this will be of interest to the Steamboat Institute audience. We saw President Trump elected in November of last year, and I think there was an expectation that by August of 2017, we would have seen repeal, but we haven't seen it. And so my first question, and I want to ask Beverly to weigh in on this, and Grace Marie as well, why haven't we seen it? You know, Grace Marie mentioned Medicaid and the Medicaid dollars that are in the minds of senators as they're voting, but there are more hurdles to repeal than just Medicaid. On the other hand, I think there's a lot of people who see this as much more simple of an issue. Repeal it. I mean, it seems so basic. But then maybe there's more to it than that. So Beverly, what do you think?
Well, first of all, I mentioned to you that a child's policy was $28. Under the Obamacare law, it was $200. So how much was it on the high-risk pool? $151. So you heard everyone say, oh, but those high-risk pools were so expensive. Remember, this was implemented in 2014. So depending on your state, you saw these rates go through the roof. And we've heard 400%, 600% difference. Do the math. If you were a 27-year-old, it went from $50. My son, his policy went from $50 to $300. We saw that in Kansas. So of course, Kansas, red state, is yelling, Repeal this mess. Just give us back the market we had before. We're down to 2 carriers. We had 17. You know, give us back what we had. You have other states, as we talked about, Susan Collins, for example, in Maine, they already had all those ACA regulations. We repeal it, the people be like, did something happen? Because nothing really changed. We already had all of this. We already had high rate. But what did they have to do in their state because of the high rates? They had, like New York, Healthy New York. It was the states subsidizing people because of their poor policies on health insurance. Their rates were so high, they already had 2 or 3 carriers, so they were doing state subsidization. What happened with the ACA? Now they have all of us helping to pay for that subsidization instead of just their state. So Susan Collins does not want to let go of the Medicaid money that helped with that and the other dollars that are being used for premium assistance, premium subsidies. We contend that if your state would look at its own regulations and amend its own regulations, policies for insurance should be so inexpensive, we don't need any premium subsidization for the state nor the federal government. You hear people who are saying, well, nobody's subsidizing my car insurance. Right, you have hundreds of carriers offering that. You don't have the federal government mandating it. May have a state mandate, but it's just to cover the people you may run into, not yourself. So as to why do we not have repeal immediately? Grace Marie and I are on the Hill all the time. When I'm there and I'm meeting with other legislators that had this kind of issue before with the ACA type policies, they don't want to let go of that money. Also, the Democrats, if you allow me, those who proponents of the ACA, did such a great job of selling this, how bad the private market is to people, because only 6% of the people are in the private market. They're afraid. I mean, we don't hear good messaging about pre-existing conditions coming from the Republican Party. It's just like, oh, but we better not do anything with pre-existing conditions. Well, you realize we already had that before. We had high-risk pools. Ooh, that's a scary term. I don't even know if we want to use that term anymore. Instead of embracing that and saying, hey, the high-risk pools worked great. We didn't have to have mandates. They're much more affordable than they are now, than premiums are now. And how many people, by the way, just to guess, have any idea how many people were in the high-risk pools? Anybody? Anything? It's because nobody has any. Somebody? Who had a hand up? Colorado, you had 13,000 people in your high-risk pool. Kansas, we had 1,200. That's it, in the whole state, who were in the high-risk pool. That's all. And let me say this last thing. In Colorado, the high-risk pool was $57 million. That's how much the state, but it wasn't state dollars, it was premium taxes that paid for the high-risk pool, not you. And then we had Obamacare, $58.6 million, plus all the subsidies, $180 million, to the tune of $239 million, 4 times more, to try to help cover the same people who had no subsidies coming from the state nor subsidies coming from the federal. So the biggest answer to Hadley's question is, because states were so different, the states that have seen their rates go through the roof were like, repeal it today, we're ready, get rid of this mess. My people all want that. And then you have other states who would not see a difference, but they want to hang on to that money.
Grace Marie, we've heard Medicaid, money, messaging. What are some of the other hurdles, and why haven't they gotten this done yet?
Well, having lived and breathed this repeal and replace effort for this whole year, it's really clear that the Congress was so focused on process that they didn't message this properly. And the process is unbelievably convoluted. You know, I'm not going to go into the reconciliation process, but it severely limits what they could include in the legislation. And that's where you saw a lot of the factions growing, saying that the regulations were most important. No, we need to do the subsidies different. No, we need to make sure Medicaid is protected or changed or whatever. So you had all these different factions within the Republican caucus who all had different agendas, which may or may not. The House had to pass the legislation first because it involved repealing all these taxes, sent over to the Senate, but they were trying to figure out how to thread the needle through the Senate process. And that was extremely difficult in order to be able to pass this with 51 votes. So they focused on that instead of, and the president never made one speech saying, one major speech saying, this is our agenda, this is what we're going to do, and this is how we're going to protect people and fix this problem. Number one. Number two, and Steve Forbes mentioned this last night, the Congressional Budget Office, which, by the way, is still staffed primarily with people appointed through the last administration and by Nancy Pelosi. And they are sabotaging this from within. When they say that 22 million people would lose coverage, no. 22 million people by 2020, whatever the date is, would decide to not buy coverage because it's too damn expensive. And they would say, let me out of this. I'm not going to comply. They somehow believe this individual mandate is magic. That if you leave it there long enough, if the penalties are big enough, eventually you'll force everyone to purchase health coverage. And so it's the individual mandate that is their mantra. If they can keep that in place, then they think that the whole system is going to revolve around that. And it really is central. It would have been repealed in this legislation. And I think also Steve was right last night. They were saying that part of this messaging was saying, well, we need to pass Obamacare, repeal or replace first in order to get rid of $1 trillion in taxes, which is not insignificant for our economy, in order to be able to pass tax reform. Well, that's really bad messaging. And if they had gone through the committee process, so they could have gotten all these different factions to come together earlier on around repeal and replace, I think they could have done this. So I think a lot of it is process, a lot of it was just arrogance in thinking, well, we now have the majority in both houses of Congress, and the president who basically is going to sign whatever we send him. As long as we can call it repeal and replace, we can do whatever we want. Well, that turns out to be nothing. I still think they're going to wind up getting something through, but it's more likely to be this step-by-step approach that Senator Alexander is talking about.
I hate to ask Dr. Meyer to speak on behalf of all physicians, because I know it's not a monolithic group, but if you could, as the doctor on our panel, sort of explain to us, what do doctors think about Obamacare? What do they think about repeal? What does the medical community, how do they see this law? Beneficial, harmful? What's going to happen next?
Well, I think in terms of the physician effect of this, we've seen more and more physicians become employees of healthcare networks. That's been the number one thing that is evident to physicians. The ability to practice in a solo group or in a small group practice has become severely restrained, and that's because you're dependent on being in network with the healthcare plan of your area, and that's a well-known tactic of corporate medicine is basically align with us or we're going to exclude you from the network and you're going to be out in the cold. So that's driving a lot of physician practice integration right now. There needs to be, like I said, the more entrepreneurial emphasis. One of the bills that's being held up in the Senate that Grace alluded to is Senate Bill 1133, and that would basically do away with the Obama mandate that banned physician-owned hospitals from taking care of Medicare and Medicaid patients. This is clearly anti-competitive behavior, and again, it's one of these things that's being held up. So I guess that's maybe a poor answer to a very focused
the
question.
employee effect is well documented too. I mean, it's not just a feeling, but it's truly it's happening. I think fewer young doctors feel encouraged to sort of embark on their own path, but they want to be absorbed as employees because that's the safer route, because that's how the insurance world works.
Exactly. We're seeing that all over the place, that physicians coming out now are less inclined to take on the risk of starting a practice with the overhead and the loans of that, and are going into ready-made practices, as it were.
Frank, what do you think from a hospital perspective the impact of the Affordable Care Act has been, and what would you say, you're hopeful if there's going to be any change, what would that look like?
Well, I think, getting back to Eric's question about the affiliation our hospitals looking with UC Health is again, that I think we're going to have to develop regional and local solutions to this because there are local and regional problems. And, you know, the narrow networks are coming at I think at the desire of a lot of different factions that employers are looking for more standardization, lower costs, those types of things. So you see employers, large employers that are sending all of their patients to a specific center because that's where they're going to get the lowest cost. What does that do to local care? It makes it very difficult because you keep losing those patients and that population. So, you know, again, I think there's a lot of different complexities to this that we have to get figured out. If we want to provide local care, we have to decide what that's going to be and to what level, and then you know, how this is going to step forward as far as the relationships and everything. I mean, we felt like with the relationship with the larger system that in Steamboat Springs we could bring more care here locally. We have a deficit in neurology care. We have a deficit in care for pulmonary patients. Things that could be done here, things that could be done with a physician on site, things that could be done with telemedicine. And again, getting back to that whole integrated record and an integrated network where we know people are being taken care of in a way that's not fragmented and siloed, but it's more to a point of knowing what's going on and how we're going to affect their health. And then working with other organizations. I'm a member of what's called the Northern Colorado, Northwest Colorado Community Health Partnership. And what we're looking for and doing is things outside of healthcare. We're trying to you know, look at housing and look at how different things are impacting kind of those social determinants of care. And as a hospital 5 years ago, I'd never been talking about this kind of stuff, but now we're really focusing on this because it is driving some of the things that we're struggling with as a hospital to be able to take care of. So, you know, there's so many different perspectives and so many different things that are influencing what's happening. I feel like we need to take a step back and start looking at what are the most critical issues that we need to deal with. You know, Eric brought up competition, but I think that, you know, when you look across the landscape and all the proliferation of ambulatory surgery centers and freestanding ERs and all those types of things over the last 5 years have done nothing to decrease costs. And in fact, I think they're increasing costs because it's creating such a supply of high technology and things that are just driving costs up because somebody's got to make a margin on that stuff. So again, I feel like competition is great. Believe me, I do. But I think that it also gets to the point where maybe it's influencing things in a negative direction right now.
I know we could spend a lot of time talking about, you know, the rural partners in medicine and bringing specialty care to local areas, and I think localized solutions are, you know, it sounds to me to be the opposite of the Affordable Care Act approach, which is sort of a nationwide solution. But we know the Affordable Care Act is very much a health insurance law, maybe more so than it is a healthcare law. Of course, the downstream effects are, you know, in our healthcare delivery. But I want to bring in Beverly here and maybe ask you to put on your health insurance agent cap and talk about the perspective from health insurance companies. Are they really the bad guys? I mean, I think we sort of feel that they are the bad guys because it sounds like they're controlling the way we get health care. I've heard lots of different things. You know, there's a mandate that people buy their product. You think that would be good for business? You think that'd be good for them? There's subsidies to help people buy their products. On the other hand, there's a ton of regulations that you mentioned that sort of tie their hands and restrict the way that insurance companies can do the business of insurance. So what do you see as an insurance agent, and what do you think the big carriers and the smaller carriers are thinking with regard to the effect of the Affordable Care Act? Tell us about insurance world.
Okay, insurance world. First of all, we have just a handful of insurance carriers around the country that are still offering private insurance. Keep in mind, they're still offering things like cancer policies, accident plans, critical illness, group coverage, et cetera, because those are profitable. But you take a nonprofit like Blue Cross Blue Shield of Kansas City, who said, we have been offering individual private plans since 1953, we're done. The ACA just spent us. We cannot do this anymore. I met with Ron Rowe just last week, and he is the director of sales for Blue Cross Blue Shield of Kansas City. And I said, I may have an opportunity. My name has been given to Lamar Alexander to testify to his committee. And would you be willing to come with me? Will you be willing to state that if it were repealed, if those regulations were repealed, you would offer private health insurance again? He said, we would offer them again, no problem. I don't know about the political aspects, though, of saying that. Does that make sense to you? Of the 17 carriers, then we only have 2 left. The other 15 have all said privately, now I have 2 that are willing to say publicly, yes, if they got rid of those regulations, we can do it. But let me clarify this. Those core 5 regulations that I talked about that caused everybody's rates to go up and carriers to leave have never been in any repeal bill. You hear about, well, they've tried to repeal it 50 times. No, they've never included this, never included the actual regulations. So even if those repeal bills passed, nobody's rates would change. We'd have the same number of carriers. Nothing would really change. So what did those repeal bills do? They said, we can't get rid of the mandate. Again, because of reconciliation, we can't get rid of the mandate. We can just reduce the fee to 0. So they say, you hear Paul Ryan say, ostensibly getting rid of the mandate. All but getting rid of the mandate. That's why you hear that. And then we're going to get rid of some of those taxes. But the actual cost drivers are still there. That's why some of us have been very frustrated with the parliamentarian process of saying, can't we convince the parliamentarian these are the cost drivers that cause this and this, that cause these taxes? Can't we say this is the cost driver? Why can't this be repealed through the reconciliation process through the Senate? That has been a dilemma that all of us have been trying to fight. So in answer to the question, insurance carriers are frustrated with trying to make this work. They are frustrated with the mandates that have been put on them, the 20% administration. I won't go into medical loss ratio. But because of that, some of them, however, quite like United, I'll name names, like United, like National Blue Cross, which is just a bunch of little Blue Crosses, they see us pushing towards single payer. They want to be the administrator of single payer. If single payer happens, somebody's got to administer all those claims. Hey, how about us? And they're hanging in there, and that's what's going on.
Wow. Okay, we don't have a lot of time left, so I'm going to ask one last question of the panel, and then I'll take a few questions from the audience. My last question for the panel, Beverly just used the word frustrated, and I think that's the way probably a lot of us in this room feel. I know for the past year or so, I work in the world of public policy, and I've done a lot of work in the health policy arena, and there's been a great amount of frustration, I would say. So my question, I'll start with Grace Marie, we'll move down the panel this way, and if each panelist could just briefly say, what is something that those of us in this room can do to learn more about this issue, and if we can have any impact, how would we do that? What do you think the future holds, and how can we in this room be a part of making that future better?
Colorado had the experience that a lot of other states could benefit from. Is my mic on? Yeah. In really having a big debate over single payer. Hadley and I were on panels last year really trying to help people see both sides of this level. Thank you, Colorado, for your overwhelming rejection of single payer, because you saw the costs and how much the hit to the economy, the hit to the medical profession that this would. So other states could benefit and learn from that experience. So talk with your friends about what you learned single payer really would mean. And talk with your state legislators. State legislators really have a lot of influence in helping to get their representatives in Congress to really get on the track that's going to allow the state. Yes, Colorado has its own challenges, but I still think you would be able to better target that money and better make decisions about what regulations work or don't work for your state than Washington can from afar imposing those on you. So talk with your state legislators whenever you can, talk with your representatives in Congress, talk with your senators, talk with the governor's staff. Look for opportunities to help them see your perspective that you want Colorado to be in charge, not Washington.
I would say we need to demand cost transparency. As a consumer, this is very, very important, and each one of us needs to do that. When you're presented with options for surgical care, care of whatever, ask to see what the actual charges are, negotiate, negotiate, pay in cash, pay with your HSA, a better rate. Write to your insurance representatives and tell them that it's not working, that your family of 4 paying $2,500 a month for insurance is really no insurance at all. I have a high deductible plan. I happen to need surgery on Monday. I'm going to be going to an institution where I can pay in cash and do it for a quarter of the rate that it would cost if I were to have it insured. And this is widespread. So we need to all become more involved consumers.
At Independent Women's Voice, we created communication kits at iwv.org for our legislators, but they're there for you to be able to see. There are also interviews about questions and answers on the ACA that I think might be beneficial to you. As far as being actively involved, let me just share with you, I get no compensation for any of the volunteer work that I do, whether it's testifying in DC or Topeka where I live, or other states. I do this just because I'm a concerned citizen. Please be a concerned citizen. Please speak up about your own experiences, about what's going on with you. Let your legislators know. Talk to them about those insurance regulations. I would also encourage Colorado, even though now with the ACA, this is moot for a while, I helped to co-author a bill called Mandate Light, which said in Kansas, as soon as we can get rid of the ACA, please God, then we would say that all carriers could write policies that did not meet any of the Kansas mandates. In other words, just write policies you think people want without features they don't want. So then it just has to state right on the policy, this does not include this Kansas mandate. You can have a $10,000 deductible if you want one. It doesn't have to cover generic prescriptions. It doesn't have to cover primary care physicians. It doesn't have to cover specialists. Pay for those yourself, negotiate those with those doctors. It's just going to cover big catastrophic things, and your premium will be a peanut. And you can go to your direct primary care physician. I help pioneer HSAs. It's important that you let your legislators know that HSAs need to be expanded to where the people who have a private policy can pay for their premium out of it and get the same tax treatment that those who have employer-sponsored health insurance receive.
I think just one last thing is understanding that healthcare is more about, it's less about what the payment structure is, and it's got to be more about health. And we've got to move to understanding how we're going to keep populations healthy, because, again, at some level, all the issues that we're having with, diabetes and people being overweight and all those types of things is influencing the cost of all this. And we really have to find a way to educate people to keep themselves healthy. And I think, again, this is going to take a long time for this to get, it didn't get broken overnight, and it's not going to get fixed overnight. We really have to take a very concerted effort to finding the things that are going to start making an impact on what's happening with healthcare. And all of the stuff that we're talking about ties together, but I would just encourage all of you to remember that there's social aspects to this, there's health aspects to this, and then you have the providers that are kind of in the middle of this right now, trying to figure out, how we're transitioning from a healthcare delivery model to a health model, and it is just going to take some time.
All right, I think we can take a few questions from the audience. So if you have a question, raise your hand up high so I can see you. We'll start on this side of the room.
Joy Overbeck. Oh, it's on. Yeah. I really want to thank the panel and you, Hadley. This has just been amazingly informative. And I had no idea, and I thought I'd been following this, that none of the repeal and replace bills and all the Falderall, Fandango they've been going through actually, fix those big five. Mm-hmm. And so I've got actually the usual two questions. Okay, one is to go down the panel, and if everybody could say whether or not there is any hope of going back to pre-2010 our freedom of choice, essentially, in our own health care. And I think most people probably did have those catastrophic insurance policies you're talking about, because people are smart enough to realize that that's probably their best route. And my second question is, there's a lot of bandying about of how it would improve health care and also cost to allow insurance companies to sell across state lines, whether that's a possibility because there are all these different state mandates also, or whether that's just, blue sky dreaming.
Okay,
So-
we'll go down the panel and we'll say, is there any hope, yes or no? And then we'll answer Joy's second question, which is about state lines. Is there any hope, Grace Marie?
There is hope, but it's not going to be simple, and it's not going to be the kind of repeal and replace that we all envisioned at the beginning of the year, but they'll get something done.
Eric, is there any hope?
I don't think we're going to get anywhere near the reduction because of the increase in healthcare costs as a percent of GDP in the last 10 years. We've gone up about 7 or 8% now to 18, 19%. I don't think that we're going to get premiums back down where they were.
If I can weigh in, I would say I think there's hope that we head in the right direction eventually, but I'm not sure that we're going to do that before we head a little worse in the wrong direction. Sometimes it's darkest before the dawn. I'm not sure if it's dark enough yet. Beverly, do you
I
think?
prayerfully hope so. I would say that in working with our legislators on the Hill, the best we'll probably get will be some sort of a state flexibility. And I'm fighting that state flexibility will let states get rid of those regulations. If Kansas and Colorado want to get rid of those state regulations, and Maine wants to keep what they have, and Alaska wants to do that, more power to you. And California, you just continue to be who you are. But let's just let Kansas and Colorado do what they want. And let me address the what you had mentioned about buy across state lines. It really won't do anything. I wish I could tell you that would be such a great idea. It's that state regulations, the reason that you have those is that premiums are based upon location. Just like car insurance, tomorrow if you go to, or today, go do a search for car insurance. What's the first question you're asked? Zip code. Because they determine how they're going to reimburse providers in your area. They've negotiated that in your area. So my daughter who lives in New York City wants to buy a policy in Kansas. She's not going to get those cheap rates because she's going to go to providers in New York. So buy across state lines really doesn't do anything. I can show you in Colorado if you bought in Denver compared to a completely different city, same policy, same you, different zip code, completely different rates. It just doesn't work.
Frank, is there any hope that patients are going to have more control in their health care?
Yes. And again, I think it gets to the consumerism and people wanting to take control of that. And I also think it gets back to what Father was saying earlier. It's going to take some guts. It's going to take some hard decisions. And we just have to keep moving the needle.
Yeah.
But if we lose hope, then what do we have?
Right. Control is just another word for freedom, the freedom to choose, and the flip side of freedom is responsibility. So do we have any more questions from the audience? Sorry, I have to follow the microphone. It looks like I'm in charge, but I'm really not. Go ahead.
Amelia Hetfield and Hadley, thank you so much for moderating the panel. And if you guys didn't notice, that was Hadley's voice too on our video, so great job. So at least for part of it, I believe.
Okay.
Anyways, I had a question about transparency. Why, to me, this seems like such a simple and straightforward opportunity for consumers to take control, but it doesn't seem to get a lot of momentum, and it's very hard to have a conversation about it. So what are the blockages or the obstacles to transparency, and where's a good starting point? Is that going to be with a repeal and replace for the Affordable Care Act, or is there a different way to approach that?
Frank, do you want to weigh in on transparency?
Yeah, I think the biggest problem with transparency is that if you walk into a restaurant, you know exactly what you're going to pay for a meal. And so you know what you're going to pay, and the restaurant knows what they're going to get for their meal. You walk into a healthcare environment, and depending on your insurance, depending on your plan, depending on whether you're insured or not, it's all different. And so to be able to quote a price to someone that is going to be their true out-of-pocket, you almost have to filter through 50 different decision trees to be able to get there. So yes, you could be told, okay, an MRI is going to cost you $1,000, but depending on your insurance product, depending on whether you're in a government program or a private insurance, it could range from $10 to $1,000. So I think that's the problem with transparency right now, is that when you're asked those types of things, you have to filter through so many different levels of very complex issues of deductibles, copays, all that type of stuff, that it's very, very hard to answer the question.
Eric, is it hard as a physician when someone asks you?
Well, it is. What I do is basically refer them to the website for the Surgery Center of Oklahoma City, which has been a groundbreaker in terms of, if you click on any body part on their website, you'll get a list of procedures and you'll get the sum total cost for everything. And that's where things are going.
I would just say, as far as insurance goes, consumer demand has led to more transparency. As people had more HSA qualified, higher deductible plans, they were wanting to know, how much is this going to cost me? So carriers, Aetna was the first one to do it, and now most carriers do this, but most people don't know it exists. It's called a cost comparison tool. If you're going to need it, your child needs a tonsillectomy, you go in, you type in tonsillectomy, it'll show you all the hospitals, it'll show you doctors, charges within the network, and what your negotiated discounted price would be. But people don't even know it exists.
And one of the things that Washington's trying to shut down is these private physician-owned surgical centers. They have better rates of patient satisfaction, of patient outcomes. They get patients out of their center. The quality of care is better. And Washington says no more of those. So that shows you Washington's command and control is shutting down the kind of innovation that consumers so desperately want.
I think we have time for just one more question from the audience. We're going to go over here.
Thank you so much, Sam Sorbo. Thank you, panelists. I just want to ask, where is the frustration? You're sitting here, we're having all of this discussion because of government-created problems.
Right. That's right.
Where's the AMA when you just said, Dr. Eric, that physician suicide is at an all-time high? Where is the organization and people speaking out and saying, this does not work, we do not want this, we do not want our government in healthcare? I'll tell you where. Our schools are teaching our children that healthcare is a right, and rights are given to them by the government. And people are growing up thinking that they are going to get health and healthcare from the government. So where is the outrage, and how can we tap into that to send this message to Washington to butt out?
Well, yes.
Eric, I really want to ask Eric, where is the AMA?
Where is the AMA on this? Well, the AMA became fragmentary a couple decades ago, and it's never recovered. It's unfortunate. We all took an oath called the Hippocratic Oath, to take care of patients, do our best. And this is, it's obviously at a fever pitch now. And we're ill prepared as physicians to act politically. If there's a single payer system or something like that, well then, sure, we'd be talking unionization and everything that follows from that. But none of us look forward to that.
Beverly, you want to?
There's two groups that actually are speaking out, Sam, and one is AAPS, American Associations of Physicians and Surgeons. They are now, many of them are cash receiving doctors. They no longer take Medicare, Medicaid, any kind of insurance. It's here's our pricing. They're speaking out. Also, another group that, however, is supporting the ACA and speaking out against repeal is AARP. And when you realize that a 60-year-old's policy was $179, is now $774, but they're fighting repeal, I hope that people are speaking out about that.
Yeah. Thank you, panelists. Another group that's doing great work and speaking out on these issues is the Steamboat Institute.
Yes,
I'm
thank
so
you.
glad that we had the opportunity to